She'll be speaking on ocular anesthesia, the various techniques, and how to optimize the outcomes.
Good morning, a warm welcome to our IC. So, the first thing in the morning, we'll start with anesthetic symphony, where our choice of anesthesia practices guides the outcome. That is, the patient comfort and the surgical precision, thereby harmonizing the cataract surgery experience. So, cataract is the highest volume of surgical procedure that is performed worldwide almost exclusively as an outpatient procedure. But still, there are significant differences in the adopted anesthesia practices in different parts of the world. So, the key questions that we have to address are the risk and benefits that is associated with one form of anesthesia over another, and the issues related to complications of each, specific sedation strategies, the level and the intensity of monitoring required for each, and the data available to back up the same. So the year 1884 is kind of a watershed year when it comes to ophthalmic anesthesia, because that is when Dr. Karl Kohler, he was friend to Dr. Sigmund Freud, the father of psychoanalysis. Both of them were experimenting with the wonder drug cocaine. When Freud saw it as an antidote to morphine, Dr. Karl, he noticed the numbing effects of cocaine. And that is when he went on to publish it in Lancet in 1884. And in the same year, Hermann Knapp, he published in Archives of Ophthalmology, using cocaine for retrobulbar anesthesia. Then later the peribulbar came, then the topical was reintroduced and so forth. So this is the broad classification of the different anesthesia technique that we adopt in our ophthalmic surgical procedure at present. Now, the choice of this anesthesia technique depends on two people, the patient and the surgeon. Now, the patient factors like the patient preference, their anxiety levels, their level of cooperation, and also the existence of ocular comorbidities like a corneal opacity or a subluxated cataract, which can prolong the duration of the surgery. If the patient is an axial myope with a staphyloma, or if the patient has a scleral encerclage in situ, there is a high risk of perforation with needle techniques. Now, if the patient is likely to get a trabeculectomy in the future, then we have to spare area for a good bleb. Then if the patient has an ocular surface disorder like an ocular cicatricial pemphigoid or a Stevens-Johnson syndrome, then we would rather not do a subtenon so that the symblepharon doesn't progress. Now, the surgeon factors like the site and the type of the incision, the complexity of the procedure, the risk of complications, the duration of the surgery, and the expertise of the surgeon. Now, the goal of anesthesia in ophthalmic surgery or any surgery in general is to provide a pain-free surgical experience, to facilitate the surgical procedure, to minimize the risk of the complication associated with the anesthesia, as well as to reduce the risk of surgical complications. Now, that thorough understanding of the orbital anatomy is essential if you're planning for any needle-based procedure. Now, the retrobulbar that was given with a 23 gauge 31 millimeter needle, you can see the needle is so close to the optic canal that easily at 41 millimeter we can inject the anesthetic to the optic nerve sheath, causing brainstem anesthesia. So in spite of it being an excellent echinacea technique with very rapid onset of action, still it's very dangerous. So then came the peribulbar, where we have a 26 gauge 25 millimeter needle, also can be given with a 26.5 needle. It's much safer, but still the risk exists. So the conventional teaching, even when I was doing my residency for peribulbar, was the Atkinson point, where the junction between the medial 2/3 and the lateral 1/3 and the supromedial part. But now we know there are safer sites for peribulbar. That is a lateralmost point at the orbit and in the medial part at the caruncle, because there the globe is safely away from the orbital margins. Now, the subtenon block, now this can be done with a needle technique as well as a blunt dissection technique. So let's resort to blunt dissection because it can negate the complication associated with needle technique somewhat. So we make a nick in the subtenon capsule, and after blunt dissection, inject the anesthetic. And this is the specially designed cannula by Stevens. It is a 19 gauge 21 millimeter cannula with a curve so that it can follow the curvature of the globe. And if you're injecting an anesthetic at around 4 ml, then it will diffuse around the subtenon sheath as well as the extraocular muscle sheath. Now you inject 2 more ml, it will also diffuse to the intracorneal space. A little bit more ml, it will act like a peribulbar, giving excellent echinacea to the orbicularis oculi as well. Now, the incidence of complications, if you see the numbers, they are very low, but considering the huge amount of cataract surgery being done, the absolute values can be significant, especially in training centers. Now, the contraindications to LA, when the patient is not consenting, he is not able to comply to an instruction, he is not able to comply to acceptable positioning in the OR, if there is an uncontrolled tremor or anxiety, if there is allergic to the local anesthetic agent, there is a grossly abnormal coagulation, there is sepsis in the area, and in cases of trauma with a perforated globe. Now, the preferred local anesthetic agent, we always mix a short-acting with a long-acting one, lignocaine and bupivacaine. The only issue, the cocktail, we cannot ensure how sterile the solution is. We can negate it by using a single solution of ropivacaine, where it is intermediate in both. Can mix hyaluronidase, epinephrine, as per your choice. Now, with the advent of safer phacoemulsification systems, smaller incisions, foldable IOLs, the cataract surgeons are shifting their focus to topical anesthesia. Absolutely no risk associated with needle injection. Also meet the high patient expectations, no downtime, immediate results, very affordable. Few tips when we are performing surgery in a topical. Yes, the incision is best kept clear corneal, limbal at the most. Then the operating time projected should be short, and we should avoid office squeezers. That is, those patients who are uncooperative when we do a tonometry or indirect ophthalmoscopy. And make sure you anesthetize both the eyes. Avoid deep sedation, because we want our patient to comply to all our instructions. So in deep sedation, that might not be possible. Start with a very dim illumination, gradually increase so that we don't startle the patient. Verbal anesthesia, extremely important. Tell the patient, we are going to place the drape, or now you're going to hear the sound of the phaco machine. I'm going to inject the IOL. You might feel a little pressure. Remember, in topical, it isn't over until it's over. When you're taking the speculum, the patient might squeeze the eye because there is absolutely no akinesia and the AC might collapse. So proper instructions, very essential. And is there any studies saying topical anesthesia has an increased risk of complication? Yes. When compared to the needle techniques and when compared to topical anesthesia combined with intracameral, topical alone increases the risk of PC-REN, vitreous loss, nucleus drop, and as well as endophthalmitis. Probably because no akinesia, the incision comes in contact with lashes and fornix, or maybe because of the increase in PCR. So there are certain factors that increase the likelihood of intraoperative pain, patient factors as well as surgical factors. In those cases, we can consider sedation. But in sedation, as I said, patient cannot comply with our instructions, and the airway, if compromised, we won't even know. In that case, a GE is better, especially in young children and in like patients who have psychiatric problems, who has delirium, because they're at least the airway and vitals are under control. Now, the monitored anesthesia care, where you have a qualified anesthesiologist monitoring the patient while you're doing cataract surgery, it might sound as a luxury, but there is data supporting high levels of subjective patient satisfaction as well as surgeon comfort. And the methods of monitoring include communication, then observing the patient, and pulse oximetry if you're doing a topical, and BP and ECG if we take sedation or GA. And all the OT personnel should have BLS training, at least one should be trained in ALS, and we should document the anesthesia procedure, whatever is undertaken. Now, just to summarize a safe practice, pre-op patient counseling, extremely important. Keep the conditions in the OR optimal. Low noise levels, dim illumination, and comfortable temperature. Appropriate patient selection and the case. There is no place for ego. Patient safety always comes first. And monitor the vitals and make sure the equipment facilities are of good standard and maintenance, especially in case of a medical emergency. Now, the search for the holy grail anesthetic still continues. And these are just tips. Now, exception is the rule in medicine. So I just want to share one case. This was a case of chronic liver disease, which I operated around 2 years back. So his INR levels were over the roof, like 3 point something. And then we gave 3 infusions of vitamin K. It refuses to budge. So it was like a diabetic patient, hard cataract. One was like NS4, other was like brown or black. So I thought I'll go for the NS4 first, because there was no question of giving any sort of block. It has to be done in a topical. So the first eye, I did topical phaco, but that time I didn't have like the best of equipments available. So there was post-operative edema for first few days, but eventually he gained 6/6 vision. For the other eye, I thought I'll do a topical SICS, but the patient was cooperative. It was possible. So even when these tips are taken into account, remember, we can tailor our techniques for every patient. Thank you.
Thank you, Dr. Manasa. I think within a short span, you've covered all the very important aspects of ocular anesthesia. To further the discussion, I just wanted to bring up this point. that now because of a lot of advertising and some relatives who have undergone topical anesthesia,